All right, Brittany, what do we got next? Oh, you're muted there.
We're only 2 years into using Zoom, so one day I'll figure it out. But anyway, so now we have a combined heat between APSO, which is the American Pediatric Surgery Association, and IPSO, the International Pediatric Surgery Organization. So hopefully this will make this extra spicy for the competition to put these two societies together.
But explain why they're together. So I'll just explain. So again, we gave every society an opportunity for 3 abstracts, and not everyone sent us in their abstracts. We tried hard, but we didn't get everybody's. So because of that, we had to combine those that didn't have a full 3 together. So this is IPSO and APSA together.
Perfect. And so the first one up is from APSA, and this is from Dr. Jason Frazier. He's a professor in surgery and the program director of the Pediatric Surgery Fellowship at Children's Mercy in Kansas City. And this paper is on his work titled The Natural History and Consequence of a Patent Processus Vaginalis, an interim analysis from a multi-institutional prospective observational study. And so the aim of this study was to define the frequency and timing of a symptomatic inguinal hernia in a group of infants with a known patent processus vaginalis. And then the other 2 presenters and presentations are from IPSO. And so first is Dr. Stephen Scoville from Nationwide Children's Hospital at The Ohio State University, presenting the comparison of outcomes between surveillance ultrasound and completion lymph node dissection in children and adolescents with sentinel lymph node positive cutaneous melanoma. And so this study was conducted using patients from 2010-2020 to compare the outcomes of patients with melanoma and a positive sentinel lymph node that underwent ultrasound observation versus those who had a complete lymph node dissection. And second for the IPSO grouping is Dr. Bernadette Jeremese from the Princess Maxima Center for Pediatric Oncology with the work Multiplex Organoid-Based 3D Live Imaging Platform to Screen Probes for Fluorescence-Guided Surgery. And so basically this is a study where they aim to show the feasibility of using probes with specific tumor targets for fluorescence-guided surgery. So remember, this is 1 from APSA and 2 from IPSO, and let's start the poll to see which one we'll watch.
All right, Brittany, do you have the winner in front of you, or you want me to tell you?
Can you tell us?
Yes, it is comparison of outcomes between surveillance ultrasound and completion lymph node dissection in children and adolescents with sentinel lymph node positive cutaneous melanoma. So that actually had a 70% win there. So pretty dominant win. So we'll come back in a minute and we'll be able to roll that video.
I'd like to thank you for this opportunity to present our work entitled Comparison of Outcomes Between Surveillance Ultrasound and Completion Lymph Node Dissection in Children and Adolescents with Sentinel Lymph Node Positive Cutaneous Melanoma. We have no disclosures. Pediatric melanoma has approximately 500 new cases diagnosed annually in children less than or equal to 18 years old. Compared to adults, we know that childhood melanoma is associated with delayed diagnosis and therefore, not surprisingly, more frequently has nodal involvement. It also has unique disease mechanisms. Despite these differences, though, management of pediatric melanoma is based on adult studies. Melanoma management is largely based on depth of the tumor as well as presence of metastatic disease. Those with disease less than 8 millimeters thick are largely managed with wide local excision, while those with metastatic disease typically involve consideration of surgical excision and/or systemic therapy. Those in the middle category of having tumors greater than or equal to 8 millimeters or less than 8 millimeters with high-risk features without the presence of metastatic involvement typically undergo wide local excision with sentinel lymph node biopsies. If the sentinel lymph node biopsy is positive, then these patients would typically undergo ultrasound observation versus a completion lymph node dissection, which has a high risk of morbidity. Within the past 6 years, 2 adult trials known as the DCOG-SLT and the MSLT2 trials helped to show that within these low to intermediate risk patients, there's no significant difference in outcomes for patients with positive sentinel lymph node biopsies who were followed with ultrasound observation versus completion lymph node dissections. However, there is no pediatric data to support one versus the other. Therefore, we set out to answer this question. Our study included patients less than or equal to 18 years old, diagnosed with cutaneous melanoma between 2010 and 2020. 14 total institutions participated through the Pediatric Surgical Oncology Research Collaborative, otherwise known as IPSO. Of the 252 patients included in this study, we found nearly equal distribution of age, tumor location, while race was predominantly white, consistent with prior literature. Breslow depth ranged from tumor in situ to 20 millimeters in depth, with a median of 2.55 millimeters, and extent of disease was nearly split between localized and regionalized disease. In categorizing our patients, we had 4 patients who underwent wide local excision alone that went on to undergo ultrasound observation. We then had a total of 227 patients who underwent wide local excision with sentinel lymph node biopsies. 111 of these had negative sentinel lymph nodes, with 6 of those who went on to undergo ultrasound observation. In contrast, 115 patients had positive sentinel lymph node biopsies, about 51%. Of those, 36 went on to have ultrasound observations, whereas 65 underwent completion lymph node dissections. Finally, 2 patients had wide local excision alone or had unknown sentinel lymph node biopsy results, went on to have completion lymph node dissections, for a total of 46 patients in the ultrasound observation group compared to 67 that had completion lymph node dissections. Comparing outcomes between ultrasound observation versus completion lymph node dissection, we found that patients who underwent completion lymph node dissection were significantly older and more likely to receive adjuvant therapy. Furthermore, there was no significant differences between recurrence or death from disease between these 2 groups. Additional subgroup analysis found that positive sentinel lymph node biopsies had significantly higher rate of disease recurrence at 18% compared to 3% for the negative sentinel lymph node biopsy group. We also found that only 21% of those who underwent completion lymph node dissection had additional positive nodal disease. However, we found that rate of recurrence was not significantly different between completion lymph node dissection patients with or without additional nodal burden. In doing an analysis based on recurrence versus no recurrence, we found that recurrence was associated with positive nodal disease, deeper Breslow depth, and greater use of adjuvant therapy, and a higher rate of death. Therefore, to summarize, pediatric melanoma presents as advanced disease with nearly 50% positive sentinel lymph node biopsy rate. Management of nodal disease had no significant impact on disease outcomes with respect to recurrence or death from disease. Only 21% of patients that underwent completion lymph node dissection had additional nodes discovered, and findings of additional nodal disease did not significantly correlate with recurrence. Recurrence did most strongly associate with positive sentinel lymph node biopsies and deeper Breslow depth. I would like to personally thank our many collaborators across the 14 institutions who helped with our data acquisition, analysis, and our manuscript preparation. Thank you.
Well, this was outstanding. Dr. Scoville, thanks for joining us.
Thanks for having me.
Brittany, Tony, any comments or questions?
I have one question. After this presentation, what I get from it is that if you have a positive sentinel lymph node, it's the same to look at with ultrasound that to do a complete lymph node resection. Is that okay?
Yeah. So essentially outcomes, at least from what we could tell, we didn't find any statistical difference between those that underwent completion lymph node dissection versus sentinel lymph node with ultrasound observation. So, and we even looked at the timeline from when the DCOG and MSLT2 trials came out. And, before those trials came out, there was a much higher rate of completion lymph node dissection, even in kids. And then after those trials, the rate has gone down, but it's still higher than what's done typically in adults. And so what we're finding is that for most children, we can, while the disease is thought to be more severe, you can still observe these patients with sentinel lymph nodes and not move forward with completion lymph node dissection.
Stephen, this is an excellent presentation. Thank you very much. In pediatric surgery, we don't see melanoma that frequently, and so it's kind of rare. So this is very helpful for practice. So the concept of doing the sentinel lymph node will then give systemic therapy. Is that correct? That's the first question.
Yep. Sorry, can you repeat your question one more time? Sorry.
Yeah, there was some background noise.
Yeah.
So if a sentinel lymph node is positive, that will then indicate systemic disease. Is that correct?
Certainly more severe disease than if there wasn't there, yes.
Yeah. But systemic therapy, I mean, you'll give systemic therapy if the sentinel lymph node is positive?
So not always. Some of those patients, so we didn't specifically look at that question among these, but we did look to see once they had those who went on to receive therapy. Obviously, if they have sentinel lymph nodes, they're more likely to get adjuvant therapy versus not. A lot of it then depends, I think, a little bit on the genetic makeup of the melanoma, and then also just the overall risk factors of the tumor itself, the size and things like that.
So my second question is then, if you do decide to do the ultrasound follow-up, what is your response if you see a lymph node getting bigger? Do you go and resect it, or do you change therapy? What is the point of the ultrasound follow-up?
Yeah, so we didn't specifically address that in this study, but I believe that you would then, if you hadn't been on therapy at that point, you would move forward with it. The other important thing is that most of these patients, you didn't have clinically positive nodes at the time of your initial dissection. So you're looking, I'm assuming your question is, if you were to have a clinically positive node at that point, what would you do? And I think the answer would more likely just be to move forward with systemic therapy. I don't think people would move forward with a completion lymph node at that time. You would just go with adjuvant therapy.
Yeah, thank you.
Thank you.
So we're out of time, but I will tell you, if you wouldn't mind, Stephen, to go into the chat. There's some questions I know Tony answered. I think Andrew Fleming's question, but questions about PET CT and things that you can go answer in the chat. So great job. Congratulations. Amazing work. And hopefully we'll be able to see you in the next round.
Thank you.
Thank you. All right. Who's next here? Whose turn is it?
Now we have.
Oh, break.
Yeah. We are a little bit ahead, so that's a surprising thing. And we are going to take a break because we already did 5 hits and there are 5 left. So we are going to take a 5-minute break so we can all go and do some stuff.
We'll see you in 5 minutes to complete the rest of the heat. Take care.